Good afternoon, I'm Swami Iyer. We're in the second day of SOHO in Houston, 2015. I have a great honor and pleasure of interviewing Dr. Susan O'Brien, who used to be from MD Anderson and now currently in Paradise, as Dr. Virda mentioned, the co-director of the Clinical Cancer Research Program at UC Irvine. Welcome, Dr. O'Brien.
Thank you.
So, Dr. O'Brien, you chaired this session, and it is always fascinating to see the advances in CLL. We've come a long ways.
Right.
And in terms of trying to put this in Bob Weinberg's words, who looked at all these cancer mechanisms, three-pronged approach: the biology, the sophisticated therapies, and the patient-specific approach. So, and there's a lot of presentations today. What are your insights into the biology, particularly vis-a-vis presentation from Dr. Wiesner, and also the genetic mutations?
Absolutely. I think what we've really learned with the B-cell receptor inhibitors is that it's not just the tumor, but the microenvironment that affects the course of the disease. And that was clearly shown with the B-cell receptor inhibitors just from the pattern of response, right? We see very rapid lymph node shrinkage, and then at the same time we see the lymphocyte count going up. And actually very early in the phase 1 trials of these drugs, some of the patients were taken off study because the physician thought that they were progressing, understandably. But then it became clear, well, that something else was going on, because although the lymphocyte count was going up, the lymph nodes were dramatically shrinking. And we now know that the B-cell receptor inhibitors interfere with chemokines that cause the cells to chemotax and adhere to the stroma. And so because you lower those chemokines, you get this initial efflux of the cells out of the lymph node and into the peripheral blood. And we know that gradually over time, this goes down and usually will resolve. Although interestingly, now we have longer term data with Ibrutinib, for example, going out 3+ years. And it's interesting that there's a small cohort of patients where even out 2-3 years, the lymphocytosis has peaked and come down, but it's still not 50% below baseline, even though their nodes might be totally gone. And we call those people PRL to designate that type of response. And we know that they're more likely to be in the patient group where they have a mutated IGVH gene, but it's a small percentage, 5%. So even the people that are mutated, most of them will resolve their lymphocytosis. What we don't know yet is that very small percentage where they don't resolve it, what's different about them. The good news, however, is that there's no data that these people are losing their responses or progressing. They're continuing to respond, and they're doing just as well as the patients who achieve a true PR. But that's a very interesting biological subset that we'll need to understand more.
And as always, even for those patients who don't need treatment, the biology has always been fascinating. And those who require treatment now with this modern era of the targeted therapies, you see more and more phenomenon, and we're still trying to understand those. But from a perspective of, from a common day-to-day community physician oncology perspective, I guess the big question, we have all these different options. It's entered the targeted therapy era like CML, but unlike CML, you have all these different options. It's good, at the same time, confusing, daunting, and the patients want the best. And you saw the debate with Dr. Keating and Dr. Nielke. So what's your take on chemotherapy and chemoimmunotherapy and the targeted therapies?
Right. So the debate, as you said, was, is it the end of chemoimmunotherapy? And I thought it was a funny debate because obviously, even though one person was arguing, saying it was the end, and the other was saying it wasn't, it kind of became clear that both of them were saying it wasn't quite the end of chemo. And I think that there's a good reason for that. We now know that there's a cohort of patients, and this is from the MD Anderson database, but the Germans have very similar data. And in fact, the MD Anderson paper and the German paper have recently been submitted. So we should see this data published pretty soon. But the MD Anderson data has been presented, and we now know that there is a plateau on the progression-free survival curve at about 10 to 14 years from the MD Anderson database. And if you look at who are the patients on that plateau, They are not the patients who have 17p deletion, as you would expect, and they're not 11q deleted. They're primarily mutated. They have a mutated IGVH gene. So the big question is, are those patients cured? Well, I would argue that even if they're not cured, if they got 6 months of chemo, so a limited time course of therapy, and 12 years later they have no disease, that's still pretty impressive. But there's some anecdotal data now that some of those patients 10, 12 years out are MRD negative. So I think there's a reasonable possibility that there is a cure fraction. We're very excited about the novel therapies. They have their own side effects, but the good thing about them, and the thing that makes them really different from a chemo-based regimen, is they don't cause myelosuppression. And we know that the biggest risk of treating CLL patients with chemotherapy is myelosuppression and infection. And they have other reasons they get infection, not just the myelosuppression, but you add it on to their own baseline immunological dysfunction. If they're previously treated, they're often T-cell depleted, et cetera. So to be able to have therapies that are not myelosuppressive, particularly in an older population, where if they get an infection, they're more likely to get sicker, is very exciting. I think, though, if we think that there's a potential cure fraction with FCR, do we really want to give those patients these novel therapies? One of the other disadvantages of the novel therapies is the duration of treatment. Right now, all the trials have been designed that they continue indefinitely unless the patient loses their response or develops a toxicity where you would have to hold it. So we tell patients, essentially you have to think of this as you're going to be on treatment for life. Maybe they won't be. Maybe we'll start seeing CRs or MRD negative CRs and be able to stop people, but certainly they're going to be on these drugs for years. And so I think that's another potential advantage of chemo, not to mention the cost, right? Because chemoimmunotherapy is so much less expensive. So I personally don't think that we're ready to completely throw out chemo. Certainly in some subsets, the classic example of the patients with 17p deletion, I wouldn't waste my time with chemo. And we don't have to, because Ibrutinib actually has a frontline approval, as you know, in that subset. But I wouldn't necessarily throw it out for everybody, and I'd particularly be worried about this mutated population where there could be a cure fraction.
No, great points. I guess if you were to take a couple of reasons to select patients for chemo: age, mutated IGVH, and the fact that you can see a good response long term, it'd be reasonable to choose this unless there's a clinical study. But for those with 17p and other mutations, even the 11qs,
yes.
You could potentially go on the novel therapies.
I would agree, absolutely, yes. So it's not one size fits all yet, I don't think.
So between the chemotherapy options, of course, the immunotherapy, the FCR as being the predominant usage here in Europe, and now you have a randomized study comparing FCR with BR. What are your thoughts on that?
Right, so that's a funny randomized trial. It's a funny randomized trial in the following sense. Whenever you do a randomized trial, there's always people who are pretty sure A is better, and in their hearts they believe it, but yes, we need to prove it in a randomized trial. And then there's always people who think B is better. This is a funny trial because whether you were on the A side or the B side, you came out happy. And the reason for that is if you thought FCR was better, you were right. But if you thought BR was easier to give, you were right. So FCR produced significantly higher complete remission rate, more MRD negativity, and a longer progression-free survival, and about a year longer, so it wasn't even really close. At the same time, it produced a lot more myelosuppression and infections, so BR was clearly an easier regimen to give. I will say that in that trial, growth factor was not routinely used, and I think most people who use FCR, certainly I would routinely use it with growth factor, and it meets the ASCO guidelines for a regimen that supports prophylactic growth factor use. But that being said, BR was easier to give. So I think, if you have a 75-year-old that's in relatively good shape and you think they can take chemo, BR is probably reasonable. But if I have a healthy, fit 65-year-old, particularly if they're mutated, as we just discussed, I'm certainly going to give that person FCR.
And there's another point in the study is pointing to the peculiarity of the study. There were a little bit more older patients and unmutated patients on the BR than the FCR.
That's true, but they did provide an analysis, and the mutation status is relevant, as you're pointing out, because we know that with chemoimmunotherapy, the patients with unmutated IGVH have shorter remissions. So that would potentially account for a difference. However, they did present the data looking within the subsets. And in fact, even within the unmutated, FCR was significantly better than BR. So although the populations weren't perfectly balanced, just randomly by accident, within the subset of mutated or unmutated, FCR was still better in either subset.
Coming to the targeted therapies, of course, you presented the frontline, also the relapse refractory data with Ibrutinib, and you've shown the 3 years, and the curve looks remarkable, just a flat line, except for one of your patients.
Right.
And even the relapse refractory, there's a small fallout, but then it's still much better than everything else that
Absolutely.
you see. So again, 17p and relapse refractory patients are great options. Age. What are the other reasons to choose the molecular targeted therapies?
I think, as you said, people who don't do as well on chemoimmunotherapy, although if you take patients who have an unmutated IGVH gene, their remissions with FCR are not bad. The durations are 4 to 5 years, which is pretty good. They don't appear to be in that plateau. So I think you could probably argue that maybe they would warrant initial treatment with a B-cell receptor inhibitor because they're not going to be in that plateau part of the curve. Can Ibrutinib be 4 to 5 years? It might be able to. You're right. We showed the frontline data with the longest follow-up, and except for one early progressor, almost all of those patients are out 3+ years now, still in remission. One caveat is that's a very small cohort. It's about 28 patients, but that's the data where we have the longest follow-up. So we don't have 4 to 5 year follow-up like we have with chemo. But if we've only got one blip on the curve, right, down at 3 years, I'm willing to go out on a limb and say, at least in the unmutated, it's probably going to be as good, if not better, than FCR. So I think that's probably another group where you could make a case for using B-cell receptor therapy up front.
Excellent. And in terms of, and you had the most experience with Ibrutinib as well in the studies, and trying to manage some of the side effects, and obviously you don't see any A's, no myelosuppression, nowhere in comparison with the chemoimmunotherapy, but in terms of some of the salient side effects, the bleeding risk or the atrial fibrillation, and what's your take on that, and how do you manage some of those?
Right. It's very interesting because the company is putting together an advisory board to actually try and come up with some guidelines on the AFib. It's not common, but it occurs in most of the trials now in about 5 to 7% of patients. We know from the randomized trial that it really does seem to be Ibrutinib related because it's significantly more in the Ibrutinib arm than the control arms. The question is, should you stop drug? Should you try and cardiovert the patient and keep going with drug? I think in the early days of Ibrutinib, we would have really tried hard to continue the drug. Why? Because in the phase 1/2, the median number of prior regimens was 4. And it's easy to say, well, stop it if they get AFib, but then what's your alternative therapy? So very early on, I think nobody was looking to stop it. Now Ibrutinib is approved for patients with only one prior therapy, so a better cohort of patients are going to get it. Should we stop? Should we not stop? The other confounding factor is that patients, if they stay in AFib, if you aren't able to cardiovert them and get them back into sinus rhythm, they need to be on anticoagulation, right? And the other risk that we know from Ibrutinib is bleeding. And we know that Ibrutinib interferes with the glycoprotein-mediated platelet aggregation pathway. Most of the bleeding that we see with Ibrutinib is mild. Bruising is the classic finding. But there have been occasional cases of severe bleeds. So now you have a patient who's on an anticoagulant because they are have AFib, and that makes it even more complicated. I know from speaking to other people that I don't think there is a consistent approach. And that's probably partly because this data has just really emerged from the randomized trial. We saw AFib occurring on the phase 2 trial, but it's an older population, 60s, 70s, comorbidities. So without a control arm, it really wasn't clear that the AFib was necessarily drug-related. I think we needed the data from the randomized trial to really be convinced on that. So this data is all relatively new. The bleeding we knew about, but the AFib we really only were sure about after the randomized trial. So I think it's a very good idea that they're going to form this panel to try and come up with some guidelines on what should we do. Should we stop drug? I think partly it depends on your alternatives. And we do have some alternatives now that are not chemo, because we know that Idelalis and rituximab is FDA approved for relapsed CLL. And so if you do need to stop Ibrutinib and you don't want to give the patient chemo, you do potentially have an alternative.
So how about Idelalis in this setting, or not just in this patients who failed Ibrutinib, but in general with 17p deletion and other mutations?
So the data is a little more recent there. We don't have quite as long follow-up. We know that 17p mutation status, et cetera, does not predict for response. Those people respond to Idelalis just as the non-17p deleted do. The data from the randomized trial that led to the approval, which was Idela and rituximab versus placebo and rituximab, has been presented. Well, the data is published, but some of the subset analysis has been presented. And so far, it doesn't look like the remission durations are shorter in the 17p deleted group, which would be somewhat different than Ibrutinib. But the caveat to that is the follow-up for the remission duration with Idelalis from the randomized trial is much shorter. So I would say I'm not completely confident in saying that the patients with 17p will have as long a remission as those without. I think it may just be that we don't have long enough follow-up to really perhaps see the curve splitting. We'll have to wait and see.
So it's obviously a good option, but I guess one of the cons, a learning experience for a lot of people who want to use this is some of the side effects that they don't normally expect to see with a targeted therapy, like colitis, pneumonias. And
I mean, there's no question that these are great drugs and they don't cause myelosuppression, but they have their side effects. Ibrutinib, as we just talked about, can cause AFib, it can cause bleeding. The side effect profile with Idelalis is a bit different. We can see transaminitis, which is usually early. The good news is that that doesn't bother the patients, right? So they're not complaining of side effects, but we have to monitor it, sometimes dose reduce. The other thing you can see is pneumonitis, and this is important for people to be aware of. Again, it's a low percentage. These kind of more severe side effects with both drugs are low percentage, but important to recognize. Why? Because if you're treating a patient for pneumonia and you're not thinking this could be a drug-related pneumonitis, you wouldn't give them steroids, and you have to think to give them steroids if you're worried that it could be a drug toxicity. That occurs relatively early. As you mentioned, the colitis is more of a late occurring side effect. And I think that the key there, and by the way, there was a white paper published based on an advisory board of experts who had used Idelalis with recommendations on the colitis, and that's a published paper. I think the key is if you have a patient who's doing great, been on drug for a year, and they start to develop diarrhea, I would hold immediately, or at least introduce a non-absorbable steroid. I think part of the issue in the original trials is because it was a late toxicity, it wasn't so easily recognized. You don't suddenly think a patient who's been on drug a year or 15 months who starts to have a little diarrhea, is having a drug toxicity. We were looking for C. diff or other things. I think one important thing is to hold or introduce a non-absorbable steroid right away, not wait as we did inadvertently for the diarrhea to get bad before we held drug. So it's just important to be aware of these things because you can't treat them if you're not aware of them. So again, the pneumonitis is early, maybe 5%. The colitis is late.
And it's very good points. As we're having a lot of experience and emerging body of literature emerging, and the comfort zone has to be established for the treating physicians, because you've also shown in your cohorts, especially with Ibrutinib, those patients who go off the study for whatever reason, they don't do as well.
Right. I think part of that, to be fair, was that, again, the cohort that went on the original phase 1b/2 had a median of 4 prior regimens. So I think our paper actually maybe has made people more scared than they should be. And what I mean by that is we showed that when patients failed Ibrutinib or had to go off for toxicity, the median survival was only a couple of months. I am very convinced that if you give Ibrutinib to a patient who's had 1 prior regimen, a lot different patient population than in that pivotal, in that phase 2 trial, and they fail, they're probably not going to have that kind of rapid progression. I think you have to keep in mind that in this original cohort, these people had failed everything, sometimes 6, 7, 8 regimens. So it wasn't just that they were failing Ibrutinib, it's that we didn't really have anything else to give them at the time. So I think you have to keep that into consideration. But that being said, most of us would agree that if the patient starts to lose their response to Ibrutinib, we would not hold until we have an alternative plan. And that's because, for example, if patients have a mutation in the BTK binding site, the drug can still bind, but it's not an irreversible bind. It's competitive binding. So even when you have a mutation in BTK, the drug still has some activity. Whereas if you completely withdraw it, then the disease rapidly progresses. So one thing that we have learned, especially in people that are heavily pretreated, is if the patient starts to lose their response, don't just stop the drug even though they're not responding. Get your plan in place for what you're going to do next, and then
just
stop the drug.
Just continue the drug and then stop
Yes.
the drug. What about monoclonal antibodies? Of course, finally, after all the work that you did with Rituxan, we have all these very strong, potent anti-CD20, the ofatumumab and obinutuzumab. It looks like we finally found the right anti-CD20 monoclonal antibody.
Well, it is kind of ironic because we have now 3 monoclonal anti-CD20s, all with a frontline label. Of course, rituximab got their label from the German study of FCR versus FC. So in the United States, the label is actually specific for FCR. And now, because of the other randomized trials that were done, we have ofatumumab and chlorambucil, which is an FDA-approved frontline option, as well as obinutuzumab and chlorambucil. The one thing we do know from the German trial, which had 3 arms, was that obinutuzumab appeared to be better than rituximab, at least when combined with chlorambucil, because what that trial showed, as you know, is that either antibody arm was better than chlorambucil alone, but then they compared the 2 antibody arms, and obinutuzumab produced about a year longer progression-free survival than rituximab with chlorambucil. So clearly better in that setting. I say that setting because chlorambucil is a very weak chemo, so the combination may the antibody may be more important in the combination in providing activity because you're starting with a weak chemo. Would that be true if we go to something like FCR, where we have a stronger chemo backbone? I think it might be, but we have to keep in mind that we don't yet have much data. But certainly potent antibodies, and ironically now we have 3 approved.
And there is a study that's looking at that FC obinutuzumab with Ibrutinib in the frontline setting.
Yes, that'll be interesting.
So, a question on, is there any implication of Notch1 mutations in the setting of the anti-CD20 monoclonal antibodies? And should we do it routinely, or when do we do
Well, we know that the patients with Notch mutations don't seem to benefit from the antibody. And again, we know that from the German randomized trial. There's a small subset of the patients. So is it, I guess the question would be, what is the financial value of being able to omit the antibody? And I should say that that is for rituximab. We don't have that kind of data with the other antibodies. But for rituximab, we have that data, that they didn't benefit when R was added to FC. But for the small percentage of patients that have it, is it worth the trade-off to do it on everybody, to do the test on everybody? But maybe it is if you save on the cost of the antibody. I don't know the answer to that, but it's not a high percentage of patients.
No, I think it's the more and more you go to these meetings, there's more clarity to CLL and the treatment options. And now the Cologne group has come up with the go, the slow, and the no-go. Of course, for the go, you have all these different options. But one question still remains, and you answered them to some extent at the presentation, the role of transplant, particularly in the upfront setting, 17p.
Right. I mean, you know that 17p deleted CLL patients were the only group that we as a CLL community would generally recommend transplant in first remission. And that's because we knew you'd be lucky to get a first remission because those patients don't respond to chemo. And if you got a first remission, you needed to try and consolidate it because once they relapsed, there wasn't much. Is that true anymore? Hard to say. Adrian Wiesner presented some data, and he has the biggest experience with previously untreated 17p. Remember, they only make up about 5 to 10% of previously untreated patients, but it's a common clonal evolution, which is why we see it in refractory patients. But on Adrian's trial that was published in Lancet Oncology, they had 35 frontline patients with 17p, so that's the biggest experience. And at 2 years, the median progression-free survival was about 82%, meaning, only 20% of those people had relapsed. So now it's harder, because would I transplant a patient who's going to be in remission, highly likely to be in remission 2 years later, particularly now that we have other drugs coming, right? Idelalis is approved for relapse. Probably by next year, we're going to have ABT-199 or venetoclax, at least for the 17p deleted patients, based on their large trial in 17p. So there are going to be other options. It's not this setting like it used to be, where you're lucky to get a response to chemo, and you might get one the first time, you're not going to get one the second time. So now I think this scenario is different, and I probably would not recommend upfront treatment of 17p patients who get Ibrutinib.
So you would wait?
I would wait.
And I know you can keep talking about CLL, it's so fascinating, but just wanted to sort of end on the newer drugs out there, and you worked on the PI3 gamma delta inhibitor as well, the Idelalis and the venetoclax that you mentioned, and then you have these PD-1 checkpoint inhibitors. So what's exciting, and what do you think in the progression of in the timeline that might get approved? Right,
so there's BTK inhibitors, PI3K inhibitors, as you just said, SYK inhibitors in clinical trials. We don't have the BCL2 inhibitor, venetoclax, yet, but we probably will, as I mentioned, by next year. I think what people are really potentially excited about is combining some of these agents. So trying to get away from chemo with its myelosuppression and infections and combine two targeted agents, assuming that, for example, if you combine a B-cell receptor inhibitor and a checkpoint inhibitor or a BCL2 inhibitor, you may get CRs, maybe even MRD negative CRs. And another big advantage of that would be the ability to stop therapy, because we know that these new kinase inhibitors are great drugs, but they're very expensive. I have to believe that that's going to be true for venetoclax also. We know the PD-1, PD-L1 drugs are expensive. So if we have a finite duration of therapy where we can get people into remission and stop therapy, that will have a huge advantage, both for the patient to not keep taking drugs and for the healthcare system with the cost. So I think probably you can combine these drugs with chemo, but then you lose this, the benefit of no myelosuppression. And so I think people are very excited about the possibility. And there are some trials underway now to actually combine some of these new novel small molecules. And they're, I think, going to be very, very exciting.
On that high note of great promise, and on the cautionary note of all the cost, and a lot of things need to be figured out, who else to navigate this very difficult field, but Dr. Susan O'Brien, thank you very much for your time.
Pleasure to be here.
Thank you.